I should introduce myself, Dr. Lee Petsonk. I, at West Virginia University, been part of this coalition 22 years. I was pretty sure that my first talk that I gave was 22 years ago. And it took me a while, really, to realize how remarkable an organization this coalition is. And I'm sure most of you realize that I don't think there's anything quite like it, where people who are both from government agencies, scientific organizations, private physicians in the clinics, and the advocates and the miners themselves. It's really a unique forum for people to work together on a problem that they all have a very different perspective on. And I just think it's unlike anything else that I am involved in, and I'm so happy and privileged to be part of this. So my perspective today, or what I'm going to be talking about, is the kind of current understanding, and it's incomplete, and what we are understanding on the pathology and the radiology of this rapidly progressive form of pneumoconiosis that we've known about for maybe about 10 years now. And so that's the topic. I'm going to go through two recent studies that have been presented but are in the process of being put into publications. The first one was just presented a couple months ago, and it's really an international collaboration. Dr. Najmuddin, who is a fellow at WVU, and he's gone into practice in Western Kentucky now, so he should be a resource for us. And then the other folks shown here. This was presented at the American Thoracic Society. And then a second study, which was presented about a year ago, that I'll also mention. Quickly, this is going to go through the background, which I think most of you are familiar with, what the methods, materials, results, and conclusions of this study were. Probably most of you are aware of the data that Anita and her colleagues at NIOSH have been generating over the last years on the chest X-ray surveillance, and how we began to see, about maybe in 2005 it was reported that there was something different. The rate of progression of this pneumoconiosis was somehow increasing, and we were seeing what we called at that time geographic hotspots, where the miners, even some very young miners, were getting disease in very short periods of time, much more rapidly than had been in the textbooks in the past. Some of the other findings that I think Scott Laney has highlighted from this data is that the X-ray appearance of the pneumoconiosis was somewhat different, and we were beginning to see increasing numbers of what we call R-type, or larger opacities. They're not the massive fibrosis, but they're larger than the very small opacities. And then another finding was that the disease was occurring more in small mines where there were fewer employees and lower seams and so on. So these were all kind of clues that what was going on. In West Virginia, we were asked by the state board of the insurance commission to kind of look into things. They kept seeing every year more and more miners with the most severe forms of pneumoconiosis, and it was really, both from a point of view of trying to run an insurance commission, it was very challenging because the resources were not adequate, and also they were concerned, why was this happening? They saw young coal miners getting disease, and every year for a decade they were getting more and more of the massive fibrosis. So we decided, well, what can we do to try to better understand it? And one of the things that we thought about was, a lot of these miners have either had lung biopsies, some of them, a good number of them, have undergone lung transplantation because their lungs would no longer support life. And sadly, some of them have had autopsies also. So we thought, well, what we should do is look into the tissues that are available. It's not really like a designed study where we sat out and said, well, we'll look for these specific types of cases. We just said any miner who has had lung tissue, we're going to try to look at that. And so we did contact the miners, and we asked either the miner or their next of kin, if the miner was deceased, to fill out a questionnaire. And just to give you an idea as to the types of things that we wanted to find out, this was our questionnaire. And you can see we asked about when the biopsy was, how old the miner was, what type of work that they did, their first mining job, what state, what county, and so on, smoking history, and then any exposures or diseases, any exposures outside of mining, and any diseases that they had. And then we had a very standardized approach to looking at the tissues that we were going to obtain. And we got what we thought were probably the world's finest 3 pathologists knowing about occupational lung disease to look at the tissues. Each one looked at them independently, and then Dr. Cohen kindly had them come to Chicago, where they looked together at each of these specimens to try to get some idea, both as an independent and then also as a consensus, what was going on in these lungs, because we thought this was information that might help us understand how to break the epidemic, to understand it. And the types of information that we collected was what lesions did they see in pneumoconiosis? Was it typical coal workers' pneumoconiosis? Was it silicosis, mixed dust disease, or this newly discovered mixed fibrosis, dust-induced fibrosis? Were there any other changes, atypical changes? And what kind of dust was in the lungs? What did they see in the lungs? So this is what we asked them to do. We actually found about 34 specimens that we were aware of. The West Virginia Insurance Commission allowed us to contact the miners, and then we had, I think some of the lawyers here helped us locate miners who had had biopsies. We were able to reach 27 of the coal miners, and of those, 21 agreed to have their tissue reviewed again by the pathologists. And unfortunately, 3 of the tissues were no longer available. The hospitals had they only keep them for about 10 years, so they had dispensed with the tissues. So we got 18, and of those 18, there was one miner who actually didn't have the rapidly progressive form, so we didn't look at his tissue, but the other 4, there just wasn't enough tissue available. They were either needle biopsies or things like that, where there just wasn't enough tissue to really say much about it. So what I'm reporting here is this group of 13 coal miners who had rapidly progressive disease and had enough lung tissue for the pathologist to really be able to tell us something about it. All were males, 12 from West Virginia, 1 from Kentucky. All of them had massive fibrosis on their chest X-ray, although the biopsies didn't always take the area of massive fibrosis, so that not all of them were clearly seen on the biopsy, but there was massive fibrosis in all 13 cases. The work that they did, 1 was just a surface miner, 8 were continuous miner operators, and 4 were roof bolters. And just a few of the results of the case description. The average age was 56, ranged from 48 to 75. The average year of biopsy was 2008, so fairly recently. This is the range from 2000 to 2012. They had worked on average about 32 years, about a typical miner's working life, 20 to 37 was the range. And only 9 of them had ever smoked, and of those 9, on average, they only had 10 pack years of smoking, so they hadn't really smoked very heavily, most of them. So I just want to show you what some of these looked like, and I'm not a pathologist, and I'm sure it's a little intimidating to try to figure out what we're seeing here, but these are example images of the massive fibrosis, and if you've ever seen lung tissue, it doesn't look anything like this. This looks more like a liver. It's solid tissue. There's no air at all in these areas, and there's a lot of scar tissue, and you can see a lot of inflammatory cells, very, very severely affected lungs. But it isn't that. There's some pigment here. You can see there's some dark brown or black pigment here and there, but not strongly pigmented as black as some of the ones that maybe you've seen in other situations. So this is the massive fibrosis that we're seeing. It's very inflammatory. The lungs are very, very scarred and inflamed, but there isn't quite as much coal dust or pigment as we would see in other typical black lung cases. Now, these are called the coal dust macules, and these are fairly typical. Some of the miners had fairly typical coal workers pneumoconiosis, but there was also a lot. This is under polarized light. You can see a lot of mineral in there. Most of what you're seeing is silicates, rock, or silica, and you can see that although there's a lot of pigment in this lesion, there's also a tremendous number of rock particles, either silica or silicates, and that was very typical. So, in addition to sometimes seeing fairly typical coworkers lesions, even there was an awful lot of rock in the lung, and this lesion is really there's not that much pigment in here. You can see this. Was a macule, but there's not nearly as much coal as we usually see. So this was called a mixed dust pneumoconiosis. It's a mixture of some coal, but mainly a lot of just different mineral particles. And this is another thing that the pathologist saw, and that was there were lesions of silicosis, here you can see what's called onion skinning of silica, and then a real rim of very, very strongly active inflammation. Here's a little bit of normal lung over here that you can see with some nice thin air spaces, but most of this is just completely replaced by silica nodule here. And here's one thing that was very unusual, and that is what's called alveolar proteinosis. The air spaces are filled with a abnormal tissue, or not tissue, but a normal fluid called alveolar proteinosis, and that occurs when the lung is just inundated with dust. When there's so much dust in the lung, then you get this alveolar proteinosis. It's often seen in what is called acute silicosis. The Hawk's Nest disaster, those men they inhaled so much silica that their lungs just filled with this liquid protein material. Now, just to summarize a little bit, when we looked at the pathologist readings, of the 13 cases, 12 out of 13 had this mixed dust type of pneumoconiosis. So this was the most common lesion in them. Almost all of them had that. And 11 out of the 13 had some lesions of silicosis. So this pointed towards not so much coal, but rock or minerals that are above or below or within the coal seam being the most important agent here. If we looked at CWP, the classic lesions of coal workers pneumoconiosis, they were seen in 5, so there was some there, but not as much as one might have thought of in just typical underground coal miners. So then I said, well, let's compare what is more. That's just the last slide just tells you about the presence of them. In other words, was there any of these types of lesions, like this? And now we're going to compare how much of each lesion there was. So in this one, for example, we're looking at mixed dust versus co-workers pneumoconiosis. And you can see in over half the cases, there was a lot more of the mixed dust pneumoconiosis than there was of the co-workers pneumoconiosis. So again, the lesion was predominantly not the typical co-lesion, but a mixture of dusts. And then when we looked at mixed dust equal co-workers pneumoconiosis, another 16%, and in only 15% of the cases were there actually more co-workers pneumoconiosis than mixed dust. So it looked like, although co-workers pneumoconiosis was an important part of this, the mixed dust seemed to be more present. And then when we looked at mixed dust lesions versus silicosis, it was a little more symmetric. You could see here mixed dust greater than silica in 23%, equal to silica in 30%. So in about half the cases, there was either about the same or more mixed dust than silica, and in about half the cases, there was more silicosis than mixed dust lesion. And then the last one is just comparing silicosis with co-workers pneumoconiosis, and you can see that there were a lot more lesions of silicosis than typical co-workers pneumoconiosis in 70% of the lung tissue that was seen. So that kind of gives you an idea, at least gave us an idea as to what we were dealing with. And I'd just like to shift to a second study that Scott Laney was the lead author on with Frank Green. It was presented a year ago. But we were trying to look at what the X-ray picture and the pathology. And this was based on a different group of miners. These were miners who had autopsies through the NIOSH co-workers autopsy program. And there were 44 miners that had been identified that had autopsies during this period and had a chest X-ray taken about 5 years before their autopsy. So they were trying to look at what does the X-ray look like compared to what eventually, when the miner died, the autopsy showed. And just a few findings from that study were of significance. It was a small number of miners, and because of that, some of the statistics were not very strong. But you can see here that of the individuals who had those irregular small opacities compared to rounded opacities, they both had a chance, about 13% had massive fibrosis. So that suggested that this so-called irregular or mixed dust fibrosis or diffuse dust-induced fibrosis seems to have, both that and the typical rounded lead to pathologic massive fibrosis. When they looked at the characteristics of those miners, those with the irregular opacities had somewhat lower underground mining tenure and a slightly higher number of years smoked and pack years. Again, the statistics were not very strong here, although the underground mining tenure was just borderline significant. So what this meant was that probably the rounded opacities required a higher degree of dust exposure, whereas the irregular opacities was associated with a lower amount of underground mining tenure. So taken in summary, and I'd be happy to answer any questions. I think the data at this point are not very strong, but at this time, it appears that this rapidly progressive pneumoconiosis is associated with high concentrations of silicates and silica in the lung. So that's probably established that is an important issue. But the rapidly progressive pattern is not generally caused by either classic lesions of silicosis or typical co-workers pneumoconiosis. It seems to be more associated with a mixed dust exposure. The pathology the pathologists say that there's a lot of cellular inflammation, so it's a very active and aggressive form of pneumoconiosis, and it leads to massive fibrosis, at least in these cases that was seen in all of these specimens. And a few of these miners with rapidly progressive disease did show this diffuse dust-related fibrosis, and also, as I pointed out, the accelerated form of silicosis, suggesting that they were getting very, very high dust levels in the mines. So I think I'll stop there, and if there are any questions regarding this, Akshay.
Thank you once again for the presentation. It was fantastic as always. The question I wanted to ask you is, coming from an area where almost all coal miners have low predominant irregular opacities, which you've very well described and educated us upon in the last 2 conferences. The question that I wanted to ask you is, when these individuals develop progressive massive fibrosis, type A opacities, are those type A opacities different in location, in shape, in size than the progressive massive fibrosis opacities that we see in the classic, coal workers pneumoconiosis with upper lobe rounded opacities?
Well, it's a very good question, and I'm not sure that I can answer it. We definitely have seen lower zone massive fibrosis and a lot of mid-zone lesions. But whether this is something that I think that the data should be available in the coal workers X-ray surveillance program to answer, but I'm not sure that it has been looked at. Does anyone aware of that? Okay. The question that Akshay is raising is he sees, in his region, a lot of lower zone irregular opacities in the miners, and that is, he's wondering when these miners with this irregular opacities or the more diffuse dust-related fibrosis go on to PMF, which they do, as was seen in this autopsy study, is the location of the mass typically different than it would be in those with more nodular upper zone disease? And I'm not aware that has been looked at in a formal way as to whether the progression from irregular opacities goes to a more middle or lower zone massive fibrosis compared to the rounded opacities.
Yeah, I mean, as far as I know, we don't have that sort of natural history of progression. On some limited cases, we may be able to look at it, but I don't know if we're going to have the data.
You don't capture that data in the B-read form because, remember, all you do is A, but it doesn't say the location of A.
Absolutely.
So you'll never be able to answer that question, it seems.
Well, would have to. I wouldn't say never be able to answer it, but you'd have to specifically go in and do a secondary analysis.
Scott and I actually talked about that. We were going to look at a study of what is the shape, size, distribution of large opacities in a way that we've done it with, the small opacities, but it would just require some funding to get bigger, to reread it with a new form that would describe that exactly.
We talked about that. It's on our list, and I think that's
Just to let the people at the back understand what the conversation is, the current classification form indicates the zone of the small opacities, but it does not indicate the location of the masses, the large opacities. So the question as to whether miners with irregular opacities go on to have, say, more predominant middle, lower zone masses is just not available through the current data systems. So Dr. Cohen and his colleagues have been talking about doing a separate study, which would require basically a new reading using different forms to determine that. But there's no question that massive fibrosis occurs in the middle and lower zones in coal miners, The issue is whether the irregular opacities tend to have their masses in a different location.
I just have one other comment and a request, actually. It seems that that biological tissue repository for miners is very important for future research, and there needs to be funding available for a nationwide biological specimen repository.
Yes, Randy.
From a medical legal point of view, are we seeing a new disease or a new presentation of an old disease?
Did everyone hear that? Is this rapidly progressive disease a new disease, or is it just a different presentation of diseases that we've seen before? You know, I don't think we can say right now. I mean, Dr. Bob is writing this up as we speak, and it's. I think there's a difference of opinion among the pathologists. I think Frank Green tends to say, you know, this is just so different that it really is something new. We're seeing a very aggressive form, a very inflammatory form of disease that looks more, what we saw in the past was a chronic progressive disease, and there was a lot of fibrosis or scar tissue, but not as much of this. You know, I can show you those slides again. There's a lot of inflammatory cells there, and Dr. Green, who's probably the world's foremost occupational lung pathologist, certainly for cold disease, believes that this is different than what he has seen in the past. So that's some evidence, but I don't think that the science right now, we would love to have more understanding of it to try to understand why are these miners getting so much cellular inflammation in their lungs, and is it some new chemical that is being used maybe in, you know, some way where just, you know, things we're not picking up to do the actual analysis of the minerals and the chemicals in the lung tissue requires extra funding. Dr. Bob and I tried to get that funding through the Alpha Foundation, but we weren't able to do that. So, you know, right, those sorts of analyses require very expensive tissue analysis and so on, and we haven't yet got that. But at least according to one very renowned pathologist, he thinks that this is something new. It's like a new type of response to the dust that we haven't seen. It's definitely pneumoconiosis, and it's definitely loaded with dust, but is there some different response due to either an immunologic or some other chemical or mineral that's associated with it? I don't think we can say right now.
Given that, would you suggest that we make a recommendation to medical examiners to start considering autopsies on these patients? I mean, in many states, occupational injuries and health issues do lead to autopsies. It's not commonly done now because the science on this is considered by the establishment to be settled, but we could certainly make a recommendation that this needs to be something to be considered. Is that premature? Do you think that would be worthwhile?
And who's going to pay for it?
You know, I think, you know, who pays for the...
The medical examiner pays by the state.
Yeah.
I just want to say quickly.
Sure.
It was interesting. I presented the same data in England at the inhaled particles meeting last fall, and one of the old guys from Scotland got up, and it was hard to understand him because of his accent, but I think he was saying that they used to see this in some collieries in Scotland where there was a lot of silica as well. We saw this before many times. But no, he went on and on like that. But so he seemed to think that there was some of this stuff that they had seen before. But I think Frank was saying in the United States we haven't seen this. But it'll be interesting to try to get some international folks to look at these slides as well, and the mineral analysis. I think will be helpful.
One of the things that I've heard in the mining industry meetings is that the cleaning plants and the beneficiation of coal has really changed over the last, 10 to 15 years, that they're much more capable of taking run-of-mine coal that's as little as 45% carbon and making a product that they can sell out of it. So that in the past, the miners were encouraged to avoid the top and avoid getting rock into the coal because they couldn't sell it because it was then wouldn't burn. But now the job, get the coal out, don't worry about the rock, we'll get it out in the processing plant. And so that is something that has changed as far as the approach to mining. Whether that's a key or not is one of the questions that we need to answer.
I didn't have a question, but more of a statement. I'm glad you brought that out at the end. It is not uncommon in a coal mine that in mining coal, and the miners should continue to mine at least 6 inches to a foot to maybe 2 feet of rock with the coal.
Howdy, Dr. Petsonk. I've got a few questions, if you don't mind. You talked about this being a mixed dust disease. What exactly do you mean by mixed dust? Is it coal and silica, or coal and silica and a whole bunch of stuff, or what?
Well, that's a good question. The lesions of coal workers' pneumoconiosis were classically defined in the pathology literature. What was it, about 1979, where the College of Pathology came out with a standard definition of the lesion, and it was typical amount of pigment and so on. And then the ashed content of the lung had a certain amount of mineral in it and so on. Silicosis is similarly defined with classic chronic silicosis, accelerated and acute silicosis lesions being defined. The mixed dust lesion has been defined more recently. I don't think it's quite as well accepted by the pathology community, but there. And I wish Dr. Green were here because he is the pathologist. But there are typical findings, and the amount of mineral in the lung when they ash it is part of how what that is about. You see an inflammatory change. It's not coal workers' pneumoconiosis because there isn't as much carbon. It's not silicosis because the pathology is not that typical onion skin lesion or the alveolar proteinosis. So it's a mixed lesion, but I don't think that the specific mineral is defined in the definition. It's more of a pathologic pattern.
Okay. I noticed that in your chart you compared mixed dust silicosis with, mixed dust pneumoconiosis with silicosis. I guess I'm wondering how.
Well, those comparisons were done. The pathologists read the tissue and they looked at it and they gave it a grade of 0 to 3 in terms of how much of those lesions. When I say silicosis, that's the classic chronic whorled lesion, rounded lesion of silica. So how many of those were there? They said 0, none, 1, mild, moderate, or severe. And when I compared the two, for example, if there was more mixed dust lesion than silica, then the mixed dust was 3 and the silica was 2 or 1. You see what I'm saying? And so in any tissue, there were more lesions typical of a mixed dust lesion than of a silica lesion. That's how the comparisons were made.
Okay, one more. You talked about irregular opacities on the X-ray in the mixed dust pneumoconiosis. Is that true in silicosis as well or not?
Well, it's a good question. Classically, silicosis has been described as a rounded lesion in the upper lung zones, and the literature suggests that the R opacities that Scott Laney has found in these areas are more suggestive, not diagnostic, but more suggestive of a silicosis pathology. But there is ample epidemiologic evidence showing that silica exposure can lead to irregular opacities as well. So, whether I don't think that irregular opacities exclude silica at all as an etiology, if that's what you're asking.
I think this has been sort of addressed earlier, but the irregular opacities, is there a pattern with the mixed dust pneumoconiosis as to where they appear first? For example, lower zones, middle.
Again, Scott did the study a couple years ago showing that predominantly the irregular opacities are in the lower lung zones. That's very typical. On the other hand, that's also the teaching. And, people do what they're told a lot of times. And so we all know to expect irregular opacities in the lower lung zones. And there may be, at least to some extent, the examples that the ILO gives, the standard X-rays have a predominance of irregular opacities in the lower lung zones. So that may, to an extent, be an artifact of the system and the teaching, but certainly what the findings were is that the lower lung zone is far and away where the irregular opacity is predominant.
One last one. UIP, IPF, whatever. Is that misdiagnosed? Is that a misdiagnosis of mixed dust pneumoconiosis?
Well, I would have to say that at least some of the time it probably is because, if you don't have pathology, and a lot of times these are these are death certificates that are just based on a clinical pattern, and if the physician didn't fully understand the amount of dust exposure. The studies that Dave Coldis did in New Mexico showed that, yes, what had been called UIP or IPF often was associated with silica exposure. So that and some other occupational exposures, including metals.
Thank you.
So since the previous questioner asked you 5 questions, I felt encouraged to ask you one more, if you don't mind. So it came as a revelation to me that classic cold worker pneumoconiosis pathological findings are relatively a small minority of the patients who were coal miners and developed rapidly progressive pneumoconiosis. So I'm going to ask you another question. Is that also true in simple coal workers pneumoconiosis, that the classic pathological findings are a minority?
Well, of course, historically, that has not been the case.
Right.
Historically, that's how the lesions were defined. So, but again, Frank Green and Val Valiathan did an extensive study of the autopsies in the NIOSH archive, and found, depending on the occupation, the roof boulders had often more risk of having silica lesions, but it was still a small minority that had anything but the typical lesions.
So the other thing that comes across in our autopsies is not that much classic findings of coal workers pneumoconiosis, but a lot of small airways disease, and of course, the company doctors say this is not due to dust, which we all know is not the case. But in your autopsy review, how much small airways disease did you see?
Well, I think we asked about the small airways disease, and it was probably more related to disagreement on the definition of that term, that we really didn't have strong findings in the area of small airways disease. I think the 3 pathologists couldn't always agree. There is an issue. When the dust deposits in the lung, it deposits at the terminal bronchiole and the first respiratory bronchioles, which are the small airways. So when is a coal macule not small airways disease? Okay, it's the macule does affect the airway. It's where it is. It can't. And so, how do you differentiate between what is simply a lesion of CWP and small airways, mineral dust airways disease. And I think that was where the definition was not entirely clear. I think maybe, Bob, you can tell me.
I think that they all had it, essentially, in our study. Because the way that they were defining it, everybody had that terminal airway involvement. That's why we had difficulty saying anything other than that all of them had involvement of the airways. If they had involvement of the airways, we sort of had to say that.
But in terms of whether, I think at least one of the pathologists said you have to see fibrotic change in that airway before I will call it small airways disease. And, a lot of these macules don't have much more than just some little reticulin change, so they don't really classify as a fibrotic change, but yet they're still going to affect the function of the small airway. Well, thanks very much. I appreciate your attention.